Hello, welcome to today's live. We'll just wait for a few more people to join before we get started. Put my phone on silent as well. Hello, just waiting for a couple more people and then we'll get going. I hope you've all had good Mondays. Always tricky the first day of the week, but over that initial hurdle, and on we go. Right, 5 of you, lovely. So let's get started. Our groin. So most of us probably know that our groin's at the inside of our hips is what we'd kind of call the groin region. So if we look at our hip anatomy initially, we've got a ball and socket joint. That is what our hip joint essentially is. So we've got the head of our femur, and then that sort of sticks out at the side pretty much. And we've got a long shaft of the femur here. And that sits really nicely in our acetabulum, which is the name for the kind of the rounded bit that covers the head of the femur, that keeps it inside. And in between the two of those, we've got a bit of cartilage called a labrum. And that allows for a bit of suction, which creates nice pressure inside the cavity so that our femur, our thigh bone, stays inside our hip joint. We obviously don't want it coming out. So in comparison to the shoulder, which I looked at a couple of weeks ago, our hip has a much deeper socket in comparison to the shoulder, which is great because that means that it's less likely to dislocate. However, it means we get slightly less movement at the hip than we would our shoulder. And we've also got 3 really big strong ligaments in our hip that help keep everything nice and in place there as well. So when we're looking at the movements that our hip does, it does flexion, so that is bringing your knee into your chest. It does extension, so if I was standing up straight and bringing my leg behind me, that would be extension. It does abduction, so abduction like being abducted by aliens, brings our leg out to the side, and adduction, so it brings the two in together. It does internal and external rotation as well, so that is if you're doing sort of like a warm-up for a sport like football or rugby, maybe you might do some opening the gate and some closing the gate with your hip. And it's just where you're bringing your leg out to the side and back in again. So we have quite a few different movements at the hip, and it makes for a very complex joint because we've got a lot of tendons and ligaments there. We've got a lot of muscles that run through, nerves all over the place as well. So there's a lot going on there. But one of the most common injuries that I tend to see at the hip here, particularly in those that play sport, is a groin injury or a hip adductor injury. So that is when the legs are coming together. The reason that I tend to see a lot of that is because I see a lot of our sporty patients, and it is an injury that's more likely to happen in a sport than it's very unlikely to be sort of a gradual injury. And it generally happens when our leg moves out to the side and our leg is trying to contract at the same time as those muscles are on a stretch. And so that's how it normally gets injured. So playing sports, it's often change of direction and you slip, or it's a sudden sharp change of direction and you kind of feel it go. I've done it myself. It was my first year at University of Hertfordshire, and it was a training match against Brunel. My coach was trying to decide whether I was going in the first team or the second team, so I was really keen, really wanted to get into the first team, and we were doing this drill and I'd pushed off my outside leg, and as I pushed off the outside leg to turn, I suddenly felt this pull in my groin. Tried to hop along and carry on playing for a bit, obviously. And then I realised I was not going to be able to play this game. I was in too much pain. But luckily it didn't last too long and I was eventually able to play. But it is, I speak from experience, a sore injury. I didn't even have a bad one. Mine was quite mild. But if we look at what our hip does movement-wise, it sort of helps to transfer the forces between the lower body and the upper body, as well as helping for sort of lower limb movements and function as well. It's actually almost like an in-between joint that helps our lower and our upper body kind of communicate and work well together because it's such a kind of stable force. And when we're looking at our hip adductors, so if you remember, that's the muscles that bring our legs together, we have got 6 of them. So we've got 3 that are called by an adductor name. So adductor brevis, adductor longus, and adductor magnus. We've then got a further 3, got our pectineus, we've got our obturator externus, and we've got our gracilis as well. So any one of them could be injured in a groin injury. I tend to see more, I'd say, adductor longus, magnus or brevis, but I have seen some pectineus injuries as well. And so with these muscles, what they all do is bring that leg in towards the body. I will try and give you an example. The chair's not in the way. So here, my right adductor, this is my right side, as I'm bringing my leg in, this muscle is working. But on the left side, what's happening is my left adductor here is working really hard to make sure that I don't go anywhere whilst my other leg is off the ground. And it helps to respond to what we call perturbation. So that is sort of different movements and forces that are felt within that area. So if I was playing sport and I was standing on one leg and someone came in to tackle me or to contest me, that's when that fixed leg is going to be working really hard, the adductors are, to keep me strong. So they've got 2 really important functions. So as I said before, a really common way to injure it is when your adductor is on a stretch, so your leg's out to the side, and then you're asking to contract it, so you're asking your body to bring that leg back in, often sudden and sharp changes of direction. The symptoms that you might experience, as I did at the time, I definitely had pain. Pain and often weakness as well, so you might feel like you can't really squeeze your legs together because it just doesn't feel quite right, it doesn't feel as strong as it did before. You'll often have what we call palpable tenderness. So that is an area where if you're poking over it, like, yep, it hurts there, that is sore. Swelling and bruising, sometimes, not always. It depends on the extent and it depends on where it is. So our muscles are really well perfused with blood, which means that they get a really good blood supply. But our tendons have got quite a poor blood supply. So often won't kind of bleed quite as much, and the tendon sits higher up into the groin, and then it goes into our muscular tendinous junction as the tendons sort of going into muscles. And that's a really common place to get an injury, is between at that junction point where the fibres are changing over. So with those kind of injuries, you might see a bit of swelling and bruising, depends how bad it is. On really bad ones that I've seen in rugby players, the bruising goes all the way down the leg, pretty much into the shin because of gravity as well. And often it feels very sudden, the injury at the time, like you sort of do it and you're like, I know something's not right. And muscles at the hip will be painful when they're contracted and when they're stretched. So if I were to ask someone to lay on their back and to move their leg out to the side, it would be painful moving it out to the side because the adductors are on a stretch, but it'd also be painful moving it in as well because they're contracting. So that would be quite indicative to us as physios that there might be a tear going on there. So initially, when we're looking at managing it, we want to make sure that we're settling down that initial sort of inflammatory phase that we get. We need a little bit of inflammation after an injury. It's a complete myth that we don't want to have any inflammation. That brings with it so much healing. So in the first 48, 72 hours, I always say to people, don't take any ibuprofen. If you're struggling with pain, you can take a bit of paracetamol. There's not as much anti-inflammatory in paracetamol as there is in ibuprofen. We want to kind of stick to what we call our PRICER or police principles, where we're kind of resting it as much as is necessary. So we're not aggravating it at all, we're protecting it. Ice will help with pain, but not with inflammation. We can't get the tissue temperature down low enough at the groin for it to make a difference to inflammation. But pain-wise, it's a great way to control your pain if you're struggling. Maybe 10 minutes on, 10 minutes off. And then we want to, if we can compress it, we will. Sometimes it can be a bit of a hard area to compress, but if we've got some tubing grip or a bandage, wrapping that sort of relatively tightly is something that we will often do as well. And trying to elevate the leg, but again, it's quite high up, so that can be a little bit of a challenge to elevate to. But they're the things that we look at in the first 72 hours. After that point, we need to get that person moving. If you have an injury like that, and that doesn't matter if it's your groin or muscle injury, anywhere else in your body, I don't have anyone resting for anything more than 72 hours, sometimes even less than that, 48 hours. And the reason for that is you're going to start to create collagen, and the scar tissue is going to start laying down. If you're just going to rest for the next 3 weeks, your collagen will start laying down quite haphazardly, and you're going to have a really crap scar. It's going to be really thick, it's likely going to be full of scar tissue, it's not going to be very strong. You're going to go back out on the football pitch or wherever you are, and you're going to injure your leg again. So we want that collagen to be laid down kind of nice and neatly and strengthened along the lines of tension. So in our groin, strengthened fairly kind of vertically downwards. And the best way to do that is to exercise it. Now, groins can be quite sort of tricky in the sense that they're quite slow in many cases compared to other muscle injuries that we see. I think often quads and hamstrings do respond a little bit quicker, but I think it's going to be mainly due to that range of motion that we get out to the side, and often that feels quite sore for a while. So I have put up quite a few posts on Instagram, so if you follow us on Instagram at onyourgame_, I put up a few posts leading up to this about different exercises that we can try. So one of the best exercises that I give people initially is just squeezing a ball between your knees, and you can try it with your knees straight. You can try it sort of laying flat on a bed, try it with your knees bent, and try it with your knees and your hips bent, so you're sort of in like what we call a tabletop position. And I'll just get people to do an isometric contraction. If you don't know what an isometric contraction is, you can watch Jess's live that she did a few weeks ago. But basically it's where we're contracting the muscle, but it's not changing in length at all. And we start with those because they're super safe. Often people aren't going to get much pain from them either. And we'll be holding them for around 10 seconds at a time if we can. I'd say generally holding up to about 50 to 70% of your strength, or as much as you're able to within your pain-free range, kind of 5 to 10 times depending on them. So they're the first exercises that we start people off with when we're looking to just get people moving. If people are able to do things like swimming or cycling as well, absolutely we get people doing those. Ab exercises you've got to be careful of, and including things like pull-ups actually. I was working at a professional rugby club once when someone had an adductor injury and they were doing pull-ups in S&C, and doing the pull-ups injured their adductor again. They had a pectineus injury. So you've got to be quite careful with ab exercises that recruit quite a lot of kind of muscles that also help with hip flexion as well, or can help with hip flexion and adduction. But other safer ones would be anything where we're kind of doing a static hold, like a hollow hold, for example, will probably be okay. So there are our initial exercises that we look at, is anything isometric. If someone's a little bit what we call higher level, so they're not in as much pain, then we will be looking to do things like wall sits with a ball between the knees and glute bridges with the ball between the knees as well. And the reason for that is we're just getting the hamstrings working a bit more, getting the quads, getting the glutes working at the same time as the adductors, just killing a few birds with one stone basically. And it just means that you're going to have less loss of muscle in other areas as well, because we don't want to be rehabbing one area and ignoring everything else. So they're the exercises that we look kind of to start with. As soon as that's kind of nice and easy for people, they're not struggling too much, we can then look at some slightly harder exercises. Again, these are up on our Instagram page. So things like side lunges, Cossack squats, short and long lever bridges as well. The other use of these exercises is for injury prevention as well. So I'll kind of try and cover two topics at once right now. But a lot of people that I see in the gym anyway don't do much work on their adductors. Often I see people on the machines, the hip adductor and abductor machines, where they've got their legs out to the side, bring them in, pushing them out. I see that a fair bit, but I don't tend to see any other slightly more functional exercises, side lunges, Cossack squats, anything like that, short, long lever bridges. And these are great exercises to do for anyone that plays a sport, or anyone that wants to have toned inside of their thighs as well. So again, these are up on our Instagram too. I don't think all of them are yet, but we'll make sure to feed some more in. The reason we want to do injury prevention stuff, I know it seems obvious, it's to prevent injuries, but there is research into this for the adductors specifically as well. So a lot of the research into hip adductor and groin injuries looks at hockey players and ice hockey players, because they're doing a lot of that side moving whilst they're kind of swinging their sticks around. So one of these studies showed that adductor to abductor muscle ratio, so our abductors mainly sit around sort of the tops of our glutes, glute muscles. If the ratio was off, meaning that if the adductor strength was at 95% or above, then they were less likely to have a hip adductor injury. For players that had 78% hip adduction strength compared to abduction strength, those players were at a much higher risk of getting injured. And overall, this study showed as well that the adductors were 18% weaker. When we're not comparing it to the abductors, we're just comparing those that were injured during a hockey season had 18% weaker adductors in pre-season compared to their friends that didn't get an injury. So you can see here, 18% doesn't sound like loads and loads, but clearly it makes a big difference in sports like hockey. And I'm sure if there were to be more studies done on football and rugby and that kind of thing, we'd probably see similar results as well. So that really shows you the importance of doing adductor strengthening regularly to help prevent an injury to start with. So we want to be able to get our adductors as strong as our abductors, and we want to make sure that overall our strength is good enough to withstand the loads of our sport. So some of those exercises that actually we use in mid-range are really important and effective for preventing a groin injury in the future as well. So I think that's something that's really important to note. Other exercises that we look to start doing are Copenhagen's. So there's quite a lot of research into these. So again, these aren't on our Instagram just yet, but they will be. For these ones, you're laying on your side, your upper leg, someone's either holding, or you can put it onto a squat rack or onto a bench, and you're bringing your underneath leg up and down, like that. And they're a great exercise for helping prevent injury, but for us, we also use them as a late stage exercise for hip adductor injuries. So this is something we'll be doing whilst we're strengthening them up, about to get them out, ready to go back to sport. So there's a few ideas for you. We also, we went through this in training actually with my staff members last week, do sumo deadlifts and sumo squats as well, because they're going to strengthen your adductors a little bit more than a standard squat or deadlift, because we're turning our feet slightly out and our stance is that bit wider. And again, we'll pop these up on the Instagram too soon so you can have a little look through them. But these are exercises that we can also go really heavy on, particularly like our sumo deadlifts. Often people will be able to get heavier sometimes on them than normal deadlifts and heavier than RDLs. And it's a heavy exercise that does really work our adductors. So that's a really good one that you can easily incorporate into your training. If you like training your glutes as well, sumo deadlifts, sumo squats, great for your bottom. So I would give those a go as well. With anyone that has a groin injury, we don't just want to send them back out running without having done some tests with them. So we always make sure that we strength test people. You can do that in a number of different ways. We actually, really simple, but we have a blood pressure cuff in the clinic. We pump it up, we record the number we pumped it up to, and we get people to squeeze with their knees the blood pressure cuff. And we get them to do that with their legs straight, with their knees bent, and then with their hips bent and their knees bent. And we can record these different scores, and we know roughly where we want them to be at. And we can see week on week, oh, last week you only got 100. Oh, this week you're at 150. Great. That's a 50% increase. So we look at that. We also look at, on the cable machines that we've got downstairs as well, we'll do single leg hip adductor strength testing, one side versus the other. And then we want to make sure that someone is really safe to be going back out and running, particularly as this injury is quite likely done when you're running, particularly when you're changing direction. So we will start our running with straight line runs and getting to the end and not pushing off and coming back. It'll just be straight line, get to the side, rest, walk around, go back again. Once I know that someone can tolerate that really well, and we've done some higher speed stuff with them as well, I then start doing something called S runs. So literally like in the shape of an S, they're running up and then running back down. So no sharp changes of direction, just gradual, almost meandering changes of direction. If they can tolerate that, we then look at our sharp changes of direction when we're hitting a cone, running off, hitting a cone, running off, up and down. But what you'll notice with those exercises is they're both still very controlled, and you're unlikely to get a hip adductor strain in a controlled environment. And this is the same for a lot of strains, to be honest. A lot of them happen in a more chaotic environment. So our rehab should be on a continuum. Down here, we've got super, super controlled exercises. I'm giving you a ball to squeeze. You're just squeezing it for 10 seconds and stop. Over here, we've got absolute chaos. You're in a sports game. People are throwing, kicking balls all around you. You've got to change direction quickly. Defenders are coming at you. You've got to evade people. That is chaos, and that's what we need to lead someone up to. So with our running, we start super controlled, just straight lines, and then we start with our snaking, and then we start with our sharp changes of direction so that we can gradually move up to that chaos. As soon as I know that someone's happy with sort of those sharp changes of direction, I then look for them to be able to respond to stimulus. So a couple of different ways you can do this, but a really easy drill. Standing in the middle of a square, and you can put cones out on each side of the square, and I can just stand there and shout, red cone, orange cone, purple cone. And you just run through the cone, run back. So this is a little bit more chaotic because that patient doesn't know where they're going to have to go to, but there's only 4 options, and they're not having to evade a defender at the same time. And they will work for about 45 seconds off. Repeat that depending on people's fitness. From that point, as soon as people are good to go there, that's when I'd start adding in a defender and some sort of more exercises that are sport-specific related. So if it was hockey, for example, someone taking on a defender, coming at them, or them being the defender, and same thing with rugby as well, getting a netball, getting people to evade that tackler or that opponent, and also getting them to be the person that's having to defend that as well. Because again, that's a little bit more chaotic before then sending them back into full training and full drills and games. And sometimes, depending on how bad the injury was and what kind of games they've got coming up, I might say, yeah, you can go on, but you're only going on for a half to start with. Let's see what that's like. Okay, that was good. Next time you can go a bit longer. And the reason for that is injuries to muscle tissue, particularly soft tissue, we see at the end of the first half of games or during the second half. And that's because we're fatiguing by that point. So if we've then, someone's not done a full 80, 90-minute game, we don't want to send them straight back out for that, even if they have done training, because it's still not going to be quite the same. And training, you still have bits that are controlled, whereas a game is kind of chaotic throughout. So that is what we will kind of look to do in the way that we kind of reintegrate people back into their training and their playing. And the other thing is a lot of games as well, if you're coming on the second half, maybe you're not quite as warm as you could be. I know on TV, if you're watching rugby or football, there's, they're on the sideline, sometimes they have bikes, sometimes they're hitting tackle pads to keep warm, which is great. But at most of the level that we kind of play sporting-wise and the people that we see here, we're not having someone there like shouting, oh, warm up, tackle me here, do this. It's kind of our responsibility to make sure we're ready to go onto the pitch. So we want to make sure that our patient and our player is nice and warm before going back to their sport as well. So hopefully you've got a good idea of some of the exercises that you can do to prevent it, and actually just how strong your adductors need to be, because they need to be as strong as your abductors when you're in a kind of sports environment like that in order to help prevent an injury. And then if you check out our Instagram, you'll see quite a few videos, and we're going to put up more videos as well. We recorded quite a lot last week for you guys too. So if you are suffering from a groin injury, or you know anyone that does, or any other type of injury, then feel free to put a comment on this. A member of the team will get back to you and see how we can help you. But has anyone got any questions? So if you've had a groin injury, if you're trying to prevent one, if you play a sport, you want to know some more specific exercises, anything like that, comment now whilst I'm still live, and I will happily help you. Cool, no questions, but if you think of any, you can just comment below, and then I will get back to you later on today as well. Thank you so much for joining. I hope you found it informative. Please feel free to give me any feedback that you have, because it helps us with the next lives. Thanks, have a good evening.